Okay, thank you everyone for joining us. We are here today for a live Facebook seminar. Joining us today is Dr. Brian Klika, a fellowship-trained orthopedic surgeon with Orthopedics and Sports Medicine Baycare Clinic. Dr. Klika is here today to discuss common hand, wrist, and elbow conditions and what treatment options are available for patients. Thank you for joining us, Dr. Klika.
Thank you, Alicia. Thank you, everyone, for tuning in and watching. Obviously, we wanted to do this live. Restrictions wouldn't allow for it, but this platform hopefully will allow us to at least disseminate some of this information. And please feel free to send in any questions. I'll try to stop periodically if possible to answer them as we go. So as mentioned, I am hand fellowship trained, so I'll try to cover some of what my subspecialty covers, and we'll start going through the information here. So just a brief introduction, just so we all know what we're going to try to cover tonight. We're going to talk about carpal tunnel syndrome, cubital tunnel syndrome, trigger finger, base of thumb arthritis, generalized cysts, both the hand and the wrist region, Dupuytren's disease, wrist ligament injuries, and tetanus elbow. I'm sure these are familiar names for many of you, but we'll kind of dig deeper so we understand what the symptoms are, management options, and what the prognosis for some of these conditions are. So first of all, carpal tunnel syndrome, probably the most familiar term on that list for many of you watching. What carpal tunnel syndrome is essentially the median nerve, which is a primary nerve that traverses the wrist, which is shown in these pictures here. It gets compressed at the wrist level. And that nerve is responsible for sensation through the thumb, through a portion of the ring fingers, as that shaded picture identifies. So often patients will discuss or they'll complain about numbness, tingling, their hand falling asleep type sensation, as some of the earlier presentations with this. As it progresses, patients will also complain of clumsiness, weakness of the hand, and sort of the hallmark night pain, often waking up, having to sort of shake your hand out. And the reason that happens is we typically fall asleep and the wrist will sort of fold underneath your chin or underneath sheets or whatnot, and be in a position that doesn't allow for adequate room for that nerve within the wrist. And that's the typical finding is people wake up and have to shake the hand out to try to get in a better position to relieve that nerve. So, why does carpal tunnel syndrome happen? There's plenty of different etiologic factors. From a pathologic standpoint, there's typically inflammation and swelling within that carpal tunnel. And you can see pictures that kind of identify that. There's several different tendons that live, I'll kind of point it out here, within this carpal canal. You can see the nerve here, how it's enlarged. And it's swollen because it's compressed and there just isn't room for it. And often it happens due to over repetitious activities, sometimes traumatic situations like distal radius fractures where there's a lot of swelling in the wrist, which can't, the carpal tunnel can't accommodate for that level of swelling. Those are some factors that can cause a lot of issues with that nerve. Also in pregnancy, there's increased swelling in the carpal tunnel. So many pregnant patients will complain of this. We can see it in rheumatoid arthritis as well. Obviously, we have certain clinical findings that will give us an idea whether this is happening. There's certain provocative testing that will be positive in patients with this. But EMG and ultrasound is excellent for this. It really can check the conduction and basically the health of that nerve in conducting messages and give us an idea if it truly is a carpal tunnel and how severe. So it really gives us an idea of how to really attack it from a management standpoint. The other thing that EMG can be useful for is it can rule out other issues. So people that are diabetic, for example, they may have a peripheral neuropathy. Individuals that have a neck level or cervical level pathology with a pinched nerve at that level, this can help rule out those other conditions that may muddy the water as to what the true factor for their numbness in their hand is. So for treatment, one of the hallmarks is bracing. that's a great first start because it really just keeps the wrist in a nice neutral position, particularly at night for the reasons that I mentioned. If it sort of bends down, gets flexed or folded in a position that does not allow opportune positioning of the nerve, the brace can counteract that. So that's a quick, easy fix. Often it isn't curative. Patients that will tell me it allows them to get better sleep, but they still often will have breakthrough symptoms. Anti-inflammatories such as ibuprofen can help mitigate some of the inflammation from a pathophysiology standpoint. Activity modification, obviously, if you can cut down on some of the repetitive patterns in the day, that's helpful, but often if it's work related, it may be somewhat impossible to do that. Occasionally we can try injections, and with injections, I'm typically talking about a steroid injection, one that can counteract against the inflammatory conditions that are there. You have to be careful with injections though. Typically we don't like using much more than a couple injections because of the risk of tendon injury. As I showed you before, the nerve lives in that carpal canal with those other tendons. So over repetitious steroid injections can cause potential iatrogenic injury of the tendons. But in earlier stages of carpal tunnel, there certainly is a place for these injections. They often can give some short-term, sometimes long-term relief. And then finally, surgery. And for surgery, what we typically end up doing is releasing the transverse carpal ligament, and that's sort of the sealing of that carpal canal. If I can just go back a slide and just show you here. Right here is that transverse carpal ligament, that white strip right there. We release that. And when we do that, we sort of unroof the sealing effect that's pushing down on the nerve. And that usually provides the most definitive option for treatment for individuals. There's several different ways of treating carpal tunnel from a release perspective, I should say. Some of the gold standards are endoscopic and open carpal tunnel release. These have the most research behind them. Typically, there's less than 15% recurrence risk with these types of releases. I'm an advocate for an endoscopic carpal tunnel release, especially in a primary situation where someone has not had any intervention previously. I feel that often people can get back a little bit quicker than with an open release, although depending on the article you look at, that may not be substantiated. It's more anecdotal from my standpoint. When you do look at studies, though, a year out, when you compare open and endoscopic releases, they have similar outcomes. So both of them, in the end, should be pretty beneficial for patients. The endoscopic release that I'm showing here, it involves a very small transverse incision. You can see the scar that is healed from an individual here in this picture. And the way we release it is we place a scope, and you can see it right here, through that incision beneath that transverse carpal ligament that I showed you, and we split that ligament. And once it opens up, the pressure isn't there pushing down on the nerve, and that's what typically leads to the relief in symptoms. We usually will recommend a splint for approximately 2 weeks, and anywhere from about 2 to 4 weeks limit lifting. And that is somewhat dependent on how people are responding to the surgery. But usually by 6 weeks, we see pretty significant recovery. Often the sensory recovery can be much quicker than the strength recovery, because if you think of some of the weakness that has incurred and some of the muscle strength that's lost or atrophy that has developed, that can take some time to recover that. We found that for pinch strength to recover, that often will take 6 weeks and sometimes 3 months for grip strength. And that's research-based, what our literature would suggest. And this is just another couple pictures here of the endoscopic technique that I use. You can see here the small little incision, and we place that scope beneath the ligament. And this is the view that we get from an actual procedure. And you can see when we get in there, this is the undersurface of that ligament. Here's the white strip from the lining of the transverse carpal ligament. And then this is the splitting of the ligament. You can see the blade splitting it and it's starting to separate here. And this is with it finely split all the way down the middle. And you can see here's one edge followed by another edge. And if you could kind of imagine that being the ceiling, if that splits apart, how there's less compression on the nerve. Now I mentioned open carpal tunnel release. This is obviously a similar release where we are trying to release that transverse carpal ligament, but there's a single incision made over top of that carpal tunnel, and the subcutaneous tissues are split, as are that transverse carpal ligament. And like I mentioned, usually at about a year, there's equivalent results when you compare open and endoscopic. And in terms of complication rate, one thing patients do, regardless of what type of release you have, they often may talk about a little bit of scar pain into that area. I tend to see a little bit more scar pain complaints with the open release than the endoscopic, but that usually, regardless whether it's open or endoscopic, is something that's temporary and usually abates within weeks to months. Any questions that have come through on carpal tunnel? I know it's kind of a big topic.
Yeah, absolutely. I can jump in, Dr. Klika. We did have a couple of questions come through from our viewers. You talked about it a little bit, but one of the questions was revolving around the outpatient surgery. In treating carpal tunnel, is it an outpatient surgery, or how long is that surgery, and maybe what does recovery look like for most patients?
Yeah, so typically if we speak from the endoscopic standpoint, it's an outpatient procedure. We typically use light sedation with local anesthetic, which allows patients to be extremely comfortable during the procedure. The procedure is done usually within 20 to 30 minutes. There is some prep time and obviously recovery. The brace is put on. There are 2 sutures in place that come out at 2 weeks, but it is relatively straightforward.
Great. One of the other questions that came through, and I'm sure this would be for any of the procedures and treatments that you'll be talking about today, obviously with the current situation with the pandemic, and we're taking precautions here by being in separate areas and that kind of thing, but are you seeing patients right now, or what advice do you have as far as people who might be interested in a procedure like this at this time?
Yeah, we do have a certain grid of restrictions and criteria. And that is something I would anticipate over, weeks to months to even open up more so. But yes, there are elective procedures that are opening. We're just making sure that it's safe, for patients, safe for staff, and testing has been completed prior. So yes, it is opening up.
Perfect. I think those are all the questions that we have. We can continue to monitor those questions as you proceed here. So if you do have questions, please feel free to ask those on Facebook. Dr. Klika, you can continue.
All right. So we'll pick up on cubital tunnel syndrome. And cubital tunnel syndrome, similar to carpal tunnel syndrome, kind of compression neuropathy like we talked about. But cubital tunnel involves the ulnar nerve. I tell patients that funny bone nerve, that nerve that when you hit the inside of your elbow and you feel kind of like a lightning zing, I go down to your pinky, that is the nerve that we're talking about. We can see here on the inner portion of the elbow, that nerve, it runs just behind what's termed the medial epicondyle in this groove called the cubital tunnel. And typically people will talk about having ring and small finger numbness. And like I mentioned, if you accidentally hit that nerve, everyone will have ring and small finger numbness. When it becomes pathologic, people will start to have this during daytime, during nighttime activity, when it's really not attributed to an injury and it's not attributed to a certain position. They also will start to talk about forearm pain and potentially hand weakness in the later stages, because that nerve, beyond being a sensory nerve, it's responsible for motor strength and motor control for some of the muscles in the hand as well. We talked about positionally. If we are in a flexed position of the elbow, which often happens in sleep, and we talked about the position that the wrist can be flexed in to cause some carpal tunnel symptoms at night. Well, if someone has their hands in against their chest and they are hyperflexing the elbow, in a similar pattern, that nerve can get compressed and cause a lot of those tingling sensations during the night. So that can be quite typical for all of us, but again, it becomes pathologic when people start to have these symptoms, out of those positions during daily activity. Typical treatment, if it's happening at night, one effective treatment is just bracing. So an extension brace that helps prevent you from getting in that flexed position. Very simply, we'll tell patients about a towel wrap, where you just wrap a towel around your elbow to maintain extension. That's kind of a quick fix to, maybe get you some better sleep so you're not waking up from it. Activity modification during the day. But beyond that, it gets a little bit tricky to treat this non-operatively. With therapy, there are some techniques called ulnar nerve glides that may be useful, but unlike in carpal tunnel, where I mentioned steroid injections being an inadequate option, we really don't have much in the way of literature to support injections for the cubital tunnel. So that in my practice is not something I offer, because I just don't see much benefit when you look at all the literature that evaluates this. If people fail, a lot of the conservative things we talk about, there are some surgical options. And these can include a simple decompression and/or a transposition. We'll talk more about this on the next slide. One thing to mention too, I mentioned about the EMG and the ultrasound for a diagnostic test for carpal tunnel. I do frequently use those tests in diagnosing this as well. Again, it can help sort of locate the issue, even though clinically I may be pretty convinced. This can really hone in and I think improve our prognosis with a positive test, as well as determine the severity of it. So for cubital tunnel surgery, there's a simple release, as I mentioned, where you simply just release the soft tissue structures over the nerve. The recovery is much quicker because you basically are just respecting that, simple soft tissue healing over the incision. Now, in individuals that have significant weakness, or in the situation where that ulnar nerve is unstable at the elbow, I typically recommend a transposition. And there's several different types of transpositions, but what I recommend is a transposition that involves moving the nerve underneath the musculature in the inner portion of the elbow. And you can see that here, and we're just moving the nerve underneath that muscle and creating sort of a new safe bed for that nerve to live in. And that's been pretty successful for people. As you can imagine though, the time for recovery for that takes a little bit longer. We have to respect that tendon healing as opposed to a simple release. It's typically a soft dressing. If we do a transposition, I often will use a wrist brace to help prevent activation of that muscle because it does move the wrist. And we usually use a sling. We do limit lifting for several weeks as well. Any cubital tunnel questions come through?
We didn't have one about cubital specifically, but I think it is applicable in terms of recovery again for these types of procedures. Someone is asking how early they can return to work. So is there any mobility once these procedures are done, and can they, brace it and then move forward, or what is your advice there?
Or are you asking post-operatively return to work?
Yes.
Yeah. So in a simple release, that typically will happen sooner just because there's less morbidity at the site. We do like a lifting restriction of probably less than 5 to 10 pounds, around 4 to 6 weeks. Now, it's, from my standpoint, I'm able to write, what a patient can and can't do. And depending on the job demand, there may be, alternative work options, light duty, that sort of thing that allows them to get back to work. But they still have to kind of carry on those restrictions. The issue is if they do too much, you certainly can compromise what we just did. Now with the submuscular transposition, we really don't do much in the way of lifting, certainly less than 5 pounds, and we don't work on strengthening in therapy for at least 6 weeks. And that's just because we have to respect that tendon repair that we did.
Great, thank you.
So now trigger finger. Trigger finger is a diagnosis that involves swelling and inflammation of the flexor tendon of the fingers. And there's two flexor tendons for each digit, with the exception of the thumb. And what can happen with this is this flexor tendon can become swollen, enlarged, or the pulley system that it glides under can thicken. And if you can imagine sort of flexing and extending the fingers as it glides in and out of that sheath, it gets stuck on it. Patients will often talk about either pain in that area or the development of clicking, triggering, or locking of that finger. Treatment can often involve a steroid injection. I feel that steroid injections are quite beneficial for this. And we aim it right over, let me go back here, right over this area where the inflammation is. And typically within about 5 to 7 days, patients will start to see some improvement. Whether that's long-lasting improvement is a little bit variable. I've had some, especially in earlier stages, where they get the injection and it does not come back. There's some individuals that it gets them through weeks to months, and eventually they are back. I've done 2 to 3 injections, but I don't think it's appropriate to get into multiple injections with this, just because of the risk, again, to the tendons. So anytime you're going above 2 to 3 injections, with the trigger finger, there is some risk to iatrogenic rupture of the tendons. We just want to be mindful of that. Now, if people fail, the conservative efforts, just like the last topics we talked about, there are surgical options, and there certainly is here for trigger finger. If we go back to this slide again, this pulley sheath that I showed you, there's one pulley in particular, okay, and it's located right about in this region. And that is a pulley that we can sacrifice in a surgery, and we split that pulley and it opens up and it allows the tendon to glide uninhibited. The important thing is, if you restrict the release to that pulley alone, it does not cause any functional issue. So it's a pretty straightforward release. Let me see if I have a picture here. I don't on that slide, but the incision is only about 1 centimeter to 2 centimeters. It's either longitudinal, oblique, or even transverse. And we're able to use that small incision to go down to that pulley and release it. There's about 2 sutures in place that come out at 2 weeks. It's, again, an outpatient procedure, fairly quick recovery, just soft dressings. Usually by a couple weeks, people are getting back to work. It's rare that patients have to go to therapy for this. That's typically only if they have, abnormal scarring in the area, but that's quite rare. I'll go through base of thumb arthritis, and then we'll see if we have any questions on either of these 2 topics. So base of thumb arthritis, CMC arthritis is another term for it. This is the second most common location for arthritis in our hand. So very common. I see many patients a day in clinic with this. Patients will complain about pain over the base of the thumb with any gripping or pinching activity. Whenever you pinch, great majority of the force is actually placed into this joint. So the force up here through pinch is then positioned down to this CMC joint. And over time, people just tend to wear it out. What happens with arthritis is there's articular cartilage. That's sort of the soft lining that lines our joints. That wears out, kind of like rubber wearing off a tire over time. And you start to develop a bone-on-bone change. And you can see in this picture, there's these bone spurs, or osteophytes is the term we'll use. And that is the reaction that our bones will sort of take with this long-term arthritis. So often patients will talk about a loss of strength. Sometimes it isn't a true loss of strength, but it's just patients compensating because they have so much pain when they attempt to grip something. There often will be swelling and enlargement from some of these bone spurs that we see in this picture. So the CMC joint is down, like I mentioned, at the base of the thumb, which is right in this area of our hand. Here's an X-ray that kind of shows you that arthritic pattern. So you see narrowing of this joint space, this whitish sclerosis right there is indicating to us that, this joint is wearing out. It has bone-to-bone contact and arthritis, and there are some bone spurs that are developing here as well. So the treatment, the hallmark treatment really is splinting. And I'll have patients that will come in occasionally and they'll tell me they're splinting, but we'll look at the splint and it's just a wrist splint that does not have any control factor for the thumb. So it's really important when you're looking for a splint for this that you have a portion that goes up to the thumb to help stabilize it. And the whole goal of this is to just give it some support so you can really, take some of that stress reaction that's propagated down to that joint. You can wear them during the day, at night, particularly during activity is when I recommend, and it seems to help patients. Beyond the bracing, there are steroid injections as well. That injection is directed right into the joint. It helps diminish, at least temporarily, some of that inflammatory change. But really, you're not going to change the process of the arthritis with the injection. It is, in some sense, a Band-Aid, but we can do typically 2 to 3 of those a year because it's a joint injection. We're not injecting around the soft tissues where the tendons may be prone to injury. So that has been quite beneficial for many patients, and at the very least has put off a surgery for some time. So in those conservative things that I mentioned, that management program fails, then there is surgery. And what we recommend for surgery is often removing that arthritic bone and trying to sort of reconstruct that joint. And that is pretty much the gold standard for the majority of patients we take care of with this. There are some situations where potentially a CMC fusion or a replacement may be a better option. In my experience, that has often been younger patients that have higher demand, where say a fusion or replacement may just last longer than the typical suspension plasty we'll talk about. The one issue with fusion replacement is the complication rate tends to be higher than that typical suspension plasty. So the suspension plasty, as I mentioned, the majority of patients we're recommending that. And the first step, again, is removing that trapezium bone. If we can go back to here, what that involves is we make an incision to remove this arthritic bone. And the second part of that surgery involves doing a stabilization for this metacarpal. If you can imagine taking this bone out of here, you start to lose the support of this bone. So we would need to stabilize it. There's several different ways of doing that. One very common technique involves using a forearm, a flexor tendon to weave either around adjacent tendons or through a hole in the base of this metacarpal to stabilize it. It's certainly one technique that I used early out, and I think it's a great technique. I've migrated to a more minimally invasive technique, though, that doesn't include harvesting tendon. It doesn't include the forearm incisions. And instead, it utilizes a K-wire that's placed through drill holes in these two metacarpals. And then a non-absorbable suture with anchors are placed underneath the skin level to support it. So it's just 2 incisions, and there's one incision over the thumb right in this area, and a second incision just over the adjacent index metacarpal. And this is just an overview of what it looks like after the suspension is complete. Here again is the void of where that bone has been removed. And patients have done quite well with that. I've found that, at least anecdotally in my practice, I think they get back a little bit quicker. That being said, I really feel with any suspension plasty that it's important to educate patients that it can take up to a year to get to your new baseline. I would say, that being said, most patients by 3 months, they're back to restriction-free work for the most part. They still have a ways to go in terms of getting their full grip and pinch strength back. But often by 3 months, they're certainly seeing light at the end of the tunnel. From a post-surgical standpoint, the splint is used for about 2 weeks. And then we transition to removable brace, sometimes casting, just dependent on the patient, for approximately another 4 weeks. So usually around 6 weeks at minimum of immobilization. That may carry out for a few more weeks as needed, depending on their pain control. Therapy is unbelievably important. You know, if 50% of this outcome is reliant on the technique of surgery, at least 50% is reliant on therapy. So, you know, working with a good occupational therapist is paramount. Maintaining compliance with a home exercise program and restrictions is really going to optimize one's outcome with this. And as I mentioned, that, you know, up to 12 months for recovery, that's important to know, just to set realistic expectations with the surgery. So any questions that have arrived, Alicia?
Yeah, absolutely. So let's talk about arthritis, since we were just talking about the base of the thumb arthritis now. There are a lot of reasons why people might have pain in their hands. What is it that's indicative of arthritis, and how does somebody get diagnosed with that versus something else?
Yep. Yeah, a lot of, you know, what I base my diagnosis on is clinical exam. And you can really find sort of reproducible pinpoint location, for example, the CMC joint arthritis, just based off the exam and where a patient has pain. There's specific tests and techniques that we can do in clinic as well to help identify it. And taking that with the combination of an X-ray that shows the X-ray findings that, you know, we kind of pointed out with the bone spurs, the joint space narrowing, advancing arthritis, that usually is pretty indicative of it. Now, I often will use injections not only as a therapeutic use, but also as a diagnostic use. So, for example, if we inject the CMC joint and perhaps it gives, you know, an individual a couple months of relief, well, it's great they got the relief, but also them getting the relief from the injection in the CMC joint really narrows down that it is the CMC joint as the problem. So in that way, it's helpful too.
Absolutely. I want to jump back to trigger finger for a moment, because we did get a couple of questions come in about that as well.
Yep.
And it's in relation to causes, or identifiable causes, I guess, for a condition like that. Jill is wondering if a fall or an injury to your hand or wrist could cause something like this, or where you see the most cause of a trigger finger.
Yeah, the most, I would say in my practice, most frequently it's from over repetition. Falls, you know, perhaps it could if you develop swelling into that area. And sometimes a fall is just enough to sort of trigger the condition, especially if it was a mild condition that pre-existed that mechanism of injury. But typically, patients that are presenting to me, it's just from overuse.
Wonderful. Another question about trigger finger that we had, and actually it goes to symptoms in general of these types of injuries. What are the early stages that you see of this before it gets that severe, or what should people maybe be looking for?
Yep, for trigger finger, very, very often patients they'll point out pain. Let me just show you here. So that A1 pulley and the flexor tendon area that gets involved with trigger finger usually is located right around this area, and kind of where the dots are here. And often in the very early stages, sort of a grade 1 finding would be maybe not much in the form of mechanical symptoms, so maybe not clicking, locking, or triggering, but pain, reproducible pain right in this area. They can kind of point to it when we walk in, and then pushing down on this area will be really sensitive to that. So that's one of the major findings.
And just going off of that again, you know, there was a question too about Kubital syndrome, where they're identifying those symptoms. Is it in the wrist potentially, or are they feeling it just in their fingers, if we go back to the Kubital syndrome as well?
Sorry, you're breaking up a little bit in regard to, was it arthritis or?
No, I'm sorry. We were just talking about symptoms in general. If people are paying attention to their bodies, pain is often an indicator of something wrong. What would your recommendations be? And as
Yep.
far as that goes, if they're feeling pain anywhere.
Yeah, I mean, if it's primarily pain, just being evaluated sooner than later is important. Um, I don't think sweeping under the rug, makes sense, especially if it's a condition that the prognosis is better if we can manage it earlier than later. So I think it's important to get in. There's a lot of tests just on clinical exam. I often will have a pretty good idea within the first 5 minutes what we're dealing with. But then you add in like the EMG, the ultrasound, x-rays, any other sort of diagnostic testing to help support that workup is really important. And we try to obviously minimize any sort of cost if it's unneeded. But I think being strategic and using the clinical exam with the appropriate tests can allow us to arrive at a diagnosis quite quickly.
Great. That's all the questions we have at the moment.
Okay, thank you. Okay, so I think we left off on wrist and hand cysts. The majority of these, they're just, I'm talking about masses in general, because these are quite frequent in the hand and wrist area, and often they are ganglion cysts, which are benign. And some of the features of a benign mass is that they're slow growing rather than rapid growth. They may fluctuate in size, especially these dorsal ganglion cysts. You're seeing a picture right here. So they may depreciate in size often because they may just spontaneously break at times. And you can see here these cysts, it's almost like a little mini water balloon, and they have a connection to the adjacent joint that sort of feeds that cyst. If they spontaneously rupture, the issue is they still have this sort of connecting stalk, which can reaccumulate in time. So that's where people often describe sort of this waxing and waning history as the size changes. They often are mobile, and they're often painful as well, particularly in wrist flexion and extension when we talk about cysts that are localized either on the dorsal or the palmar surface here of the wrist. So some of the most common cysts that we'll see, and just in general, are the dorsal wrist cysts, which we were just talking about, on the same position, but on the volar side, or the same distance on the volar side. There would be volar cysts that can occur sort of on the radial side of the wrist. And then finger interphalangeal joints. So right at the tips of the fingers is a very common place that a mucus cyst, which is a type of ganglion cyst, can develop. That usually has a pretty significant association with arthritis. And then there's finally a cyst on the flexor side. If you recall where we were looking at the diagram of trigger finger, right in that area, small little ganglion cysts can develop, overlying the flexor sheath. Treatment options can include aspiration, where you actually place a needle into the cyst and aspirate the contents. Some will actually include a little steroid injection with that to help prevent recurrence. But in general, aspiration is sort of riddled with this high recurrence because that connecting stalk, which we see right here, when you aspirate, it's still there. So the membrane itself and that stalk is still there. You just sort of deflated that water balloon, and often it reaccumulates. And that's why the recurrence risk is fairly high with aspiration. Now, if patients attempt an aspiration, or if they want to forego an aspiration, they're looking for a definitive cause, surgical resection is certainly an option. We often will take the cyst intraoperatively, and we send it to pathology. So under a scope, we're actually able to determine the definitive pathology. And after we remove any wrist cysts, and I'm talking primarily of a dorsal and the volar ganglion cysts, we often will recommend a splint for a couple weeks just to help limit the amount of pain as well as postoperative scarring. So one other thing just to bring up too with cysts is, if patients are coming in, they're just concerned about it, they're wondering what it is. If it is consistent with a ganglion cyst, I mean, there's nothing at all wrong with observation. I mean, when we talk about doing surgery, it's because it's a symptomatic cyst. And frequently I will have patients that stop in, they're just kind of wondering what it is. And almost all the time we're observing that. And sometimes just a wrist brace, for some of the occasional symptoms they have, is a great first step. So now we're going to talk about Dupuytren's disease. And Dupuytren's disease, it's a fibroproliferative disease of the palmar fascia of the hand. So the palmar fascia, that's located in this area of the hand. All of us have palmar fascia. It's just essentially connective tissue. And in some individuals, they can develop sort of hyperactivity of that connective tissue, where the myofibroblasts, which is a cell type within that tissue, can become overreactive. And there's this fibroproliferative change that will occur. It affects the MCP and interphalangeal joints of the hand in the later stages, where these flexion contractures can start to happen. It has a genetic predisposition as listed there. Some of the risk factors also include alcohol use, cigarette use, and there is a seizure link as well as diabetic link. So there's several different stages. The earliest stages, that connective tissue, okay, that palmar fascia, it forms just a small nodule, okay? And often I'll see patients in this stage, and they're not necessarily symptomatic from it. They're just curious as to what it is. Often these are non-painful. They just notice sort of a mass. If it is painful, it's usually when people are trying to make a fist and they're bringing something into their palm against the nodule, and that's what bothers them. Now, if this progresses, it can progress to stage 2, where it starts to develop sort of a cord here. You can see how this cord is starting to develop from the nodule, and you can see how it will sort of connect here to the finger and start to create a flexion contracture. What I mean by flexion contracture is an inability to get the finger straight, and it sort of adopts this flexed position. So the severity of that can then progress. And you see in stage 3, when the fingers are actually brought down into the palm, it's a severely dysfunctional problem. It gets really difficult for patients to use their hands to manipulate objects. Just some things as simply as handshakes, putting your hands in your pocket starts to become impossible. Now, in terms of management options, and the first thing, if we go back to this slide, just to bring up in terms of management options in this early stage, we typically recommend observation, okay? Because surgically you really can't improve the function of the fingers because there isn't any sort of flexion deformity that has been initiated. And for this nodule, surgery or any sort of interventions usually only recommended if patients are having pain with this. And that usually is quite rare. But when we start to get to this level, when the flexion deformity starts, especially anything beyond 15 to 20 degrees of contractures, that's when we usually recommend intervening. This is certainly a situation we talked about, someone having pain or someone having some sort of dysfunction, the importance of being evaluated sooner than later, because I will have patients that will come in, they have this deformity and it's the first time they've been seen, yet they've had this condition for 5 to 10 years. And the trouble with that is, taking care of a condition when you have this flexion deformity, trying to do surgery in this situation versus this is completely different. And there's just such a higher complication rate trying to improve it with a stage 3 versus 2. So I think it's important to just be proactive about having this checked. Now, we were looking at treatment options. So Xiaflex is one option. This is a non-surgical option, and it's indicated for patients that do have a flexion contracture. Again, you wouldn't want to just inject this into a nodule if it's there, because it's really going to defeat the purpose. What this does is we inject it into, if I go back again, a portion of these cords, and it creates sort of a weak point in that cord. Patients then often come back to clinic a day or two later, and when that has sort of enzymatically debrided a portion of that cord, we then perform a manipulation to straighten the finger. Okay, so this is just one example of a clinic-based procedure. So the injection was performed. You can see sort of the flexion contracture here. After the manipulation, this patient was able to get his hand flat for the first time in, I think it was 5 to 10 years. Obviously, he could not do this, pre-injection because of that flexion contracture. So other options include a needle aponeurotomy, and what that is it's needling. If we go back again here, it would be needling of that connective tissue of that actual cord to, in a similar way to the Xiaflex, create a weak point in it and manipulate it. So that's another non-operative option. The one downfall of the Xiaflex and the needle aponeurotomy is, all of this cord tissue, sorry, I'm going back and forth, but all of that cord tissue that is there stays there. All we have done is created a weak point to manipulate it to allow full extension. So typically the recurrence risk of this contracture coming back is much higher in, a Xiaflex or a needle aponeurotomy situation. So the other option is surgery. And with surgery, we do what's termed often a partial fasciectomy, where this Brunner style or a Z style incision is made to help prevent recurrent flexion contractures. And the aim of the surgery is actually to remove all of that cord tissue. So we're able to improve that flexion deformity as well as take out the cord material. So often our recurrence risks are moderately better than the other options because all that cord tissue is removed. Now, from a recovery standpoint, I would say even with the Xiaflex injection, there is some bruising, and it certainly is several weeks before some of the pain from the bruising and swelling goes down. But often for the surgery, it takes a little bit longer because as you can imagine, it's a pretty big incision, and we have to ensure that all that heals up appropriately. We often will give patients a night splint that helps maintain that extended position to help prevent recurrence postoperatively. And this is just a kind of a summary of the pros and cons that we just went through for those different treatments. Again, needle aponeurotomy and Xiaflex, it is not surgery. There's less wound complications, but again, the higher recurrence risk. That's the one con of those non-surgical options. With the surgery, again, you're dealing with potentially wound healing issues, or it takes a little bit longer to heal because of respecting the wound healing. But again, less recurrence risk because we're trying to remove as much of that cord tissue as possible. So the one important thing that I tell all patients with this is there is no cure. So any of these management options we talked about, none of them have 100% cure rate. So it's important to just be vigilant and come in if there is recurrence, just so you don't get the point where the fingers are in the palm and you start to create a really challenging situation surgically. So this just kind of exemplifies it. This is a good outcome, flat hand, but if you're not watching, it can go ugly quickly. Any questions that have come up, Alicia?
No specific questions, but I've heard you say it a few times today, and we've had some questions about, just getting in and seeing that appointment if there's something that you think is not right. So talk about treating this one specifically in the early stages. How important is that for people to kind of just get in and see you and see that physical exam?
Yep, I think number one, a lot of patients are in sort of the first stage that we looked at, and education is a big piece of this. They're wondering what exactly this mass is, what does it mean, what's the prognosis, and will it progress to sort of the flexion deformity. So I think just arming patients with the knowledge of when we need to intervene. So I typically tell them what sort of parameters we're looking for to intervene, and often it's when you can't get your hand flat because the flexion contracture has started, and that's very easy for a patient to sort of understand and track. And when that happens, it's much easier to take care of that as opposed to a ring finger that is stuck in the palm. So I think that's really helpful for patients.
We did have another question that came in about cysts, and I think you talked about it a little bit as well, just kind of that observation method. Are there other options for cysts as far as like therapy or that kind of thing to make them go away, or is that part of that automatic flexion kind of in size that you notice?
Yeah, often with cyst bracing is a nice non-operative option that, helps prevent people from getting into a hyperflexed or extended position, because that if it's a wrist cyst, that's often the provocative positions, like push-ups, for example. Patients will often tell me, there's certain yoga positions that really bother them. So, avoiding that, if you have a brace on, obviously it protects it, but it does kind of limit some of those activities as well. But really, beyond, the aspiration or an aspiration with injection, we are somewhat limited in terms of, treatment options for it.
Great. That's all the questions we have for now.
Okay. All right, great. So we'll move on to wrist ligament injuries. Often these injuries can be categorized as either degenerative or traumatic. With the traumatic setting, that's usually an acute problem where there really was no pre-existing symptoms whatsoever, and there was a mechanism of injury, and now patients are starting to complain of the wrist pain. With a degenerative condition, that is something that often happens over time, where there's just a slow wear and tear of the ligament, and often there's a subtle injury that sort of breaks the camel's back, and they're in to see me because it's a dysfunctional pain. Often patients will have a persistent wrist swelling. Sometimes they'll talk about sort of clicking or locking in the wrist. We often will start with x-rays for evaluating because the wrist ligament injury is a soft tissue. However, though, often we won't pick it up with an x-ray, and we may need an ultrasound and or most commonly an MRI to evaluate it. If it truly is a wrist ligament issue, we often will trial bracing or splinting first. We can do a below elbow brace, but also we'll use a Munster splint, which is listed here because this type of splint that goes up above the elbow, it prevents rotation of the wrist, which often will be quite symptomatic for people with a wrist ligament issue. Injections can be useful, so steroid injections into the area to help really cut down a lot of the inflammation. That can help settle it down in combination with a brace. Then there's also surgery, which usually constitutes a wrist arthroscopy. And the wrist arthroscopy, its picture is kind of shown here. A small scope is placed within the wrist, and we use these almost less than a centimeter portal incision. And they're placed through those small incisions, a minimally invasive technique that really allows us to visualize for any pathology within the wrist. So an MRI is quite sensitive and specific for these, but it's not perfect. And the gold standard is a wrist scope. So often we are using this not only as a treatment, but diagnostic while we're in there. It really allows us to target what the true pathology is, and we usually do the treatment the same day while we're in there during the operative case. Post-operatively, if we either debride or if we fix the ligament injury, it's usually at minimum 6 weeks of immobilization because we really want to respect the healing. And again, this is a diagnosis and a surgery that really requires extensive post-operative therapy. So working with a good occupational therapist is extremely beneficial as well. So next, tennis elbow. What tennis elbow is it's a tendonitis type condition that affects the muscles on the outer portion of the elbow, as is shown here. And this tendon junction, it really allows and provides wrist extension as well as some digit extension. And patients often will talk about pinpoint tenderness right in this area. It's really easy to identify clinically because palpation right over that area is extremely painful for patients. Often there's hypovascularity and chronic inflammation at that origin, and there's tendon breakdown over time. Occasionally people will partially, if not fully, tear this tendon as well. More often than not, that may be associated with a single high energy mechanism of injury. But from a the tennis elbow diagnosis standpoint, it's usually due from chronic repetitious microtrauma to the area. Braces are effective, steroid injections, and again, this is an area where I try not to perform much more than 2 to 3 injections, just because you are injecting around the tendon, and repetitive injections can cause weakness over time, anti-inflammatories, and activity modification. So our trial period for conservative management often is anywhere from 3 to 6 months, sometimes even longer. And most of our studies would suggest that if you are involved in a comprehensive conservative program like is listed, about 70% of people will recover from tennis elbow without surgery. There is a subset, though, as you can imagine, that don't recover, and there are surgical options. There are a couple options here. There's a minimally invasive option. It's called 10X, or the FAST procedure. And it's a minimally invasive method that allows us to remove some of that poor degenerative tissue and restart the healing process. And it's just with a percutaneous incision. There's also a surgical open debridement, which is sort of the gold standard. I provide both of these. I think they're both good options. There's subtle variances as to when I think one procedure is better than another. But typically people do quite well with them, but often 6 weeks of immobilization, of helping remove some of the wrist motion that typically that tendon that you operate on is responsible for. And then again, working with an occupational therapist or hand therapist to help optimize your strength when we're able to meet that goal and when the initial healing process has completed. So that 10X procedure, it's performed under local anesthesia. I've got a picture, I think, following this that I'll show you. There's a micro tip of it that is inserted into that affected area under ultrasound guidance. We're able to identify exactly where the area of concern is and really hone in the treatment. It releases this ultrasonic energy, which breaks down and emulsifies the scar tissue and then aspirates it up. So it's a pretty quick procedure, local only, and just a percutaneous incision, no sutures. This is just a picture of it right here. You can see this is the ultrasound. We're able to, with that microtip, identify exactly where we need to go. So often, light daily activity for 3 weeks. Although people or patients get back a little bit quicker than with an open debridement, we still, as mentioned here, we try to limit significant lifting for about 6 weeks just to respect the healing. So just one other quick point on this, for the open debridement, if someone has had substantial tearing or there's an ultrasound that's showing significant tearing that may actually require repair of the actual tendon, that's a situation where I usually recommend an open debridement, just because it allows us to identify it and do the repair. If you were to perhaps do a 10X procedure in a situation where there's a full thickness tear, there'd be no way to do the repair at the same time. You'd have to perform an open incision to do that. So that's some of the criteria that I use in determining who'd be appropriate for either of those. So I think that concludes the topics we wanted to cover today. I don't know if there are any other questions that are coming in.
We did have one question just specifically related to, if patients are dealing with these types of symptoms, what is their next course of action, or what do you recommend?
Yeah, so as we kind of talked about, just getting in to see an orthopedic specialist. Obviously, I'm hand fellowship trained, so any of these conditions, elbow, wrist, hand issues, I think, being evaluated by someone that's fellowship trained, you're going to have the best chance to hopefully be diagnosed quickly and have an appropriate management plan arranged so you can get back to good function quickly. If you wait it out too long, you can really put yourself, as well as the surgeon, in a situation where you've made the cure or, hopefully the treatment much more difficult than if it, would have been evaluated months earlier. Absolutely.
Dr. Klika, we certainly covered a lot of information today. Is there any key takeaways that you want to share just before we leave our viewers today?
No, I think, just sessions like this the number one goal I think all of us as providers should have is just to educate. And I think it's enjoyable tonight just to kind of go through and educate patients about these conditions, because when you understand what's going on with you, with your body, and you can come in and find out what exactly is going on, how it's affecting you, and what the treatment is, you're able to make informed decisions. So, I'd definitely recommend, even if it's a call or contact to a clinic just to get in, and we can help direct and guide what the next step would be. But we're always happy to help and happy to take any questions you may have.
Absolutely. Well, I want to thank you, Dr. Klika, for spending some time with us today as well. I think everything was very informative. As Dr. Klika mentioned, if you do have additional questions, please feel free to ask them in the comments below. This post will remain live, and we'll go ahead and answer those questions for you after we conclude the live broadcast here. Again, Dr. Klika is an orthopedic surgeon with Orthopedics and Sports Medicine Baycare Clinic. To learn more or to request an appointment, you can visit baycare.net. Thanks, everyone.